we're going to start off by going through the valvular problems on the left side of the heart. Now, that is what is emphasized in most clinical books, but step one is also testing problems on the right side of the heart. But I'm going to assume if you understand aortic stenosis, you'll be able to figure out pulmonic stenosis. The changes are almost identical in the opposite side of the heart. Now, we're going to begin here with mitral stenosis. Now, we're interested in the abnormal physiological aspects. So the first big point is you have an opening problem of the mitral valve. Because it does not open properly, it acts as a major resistance point in series. And because it's a major resistance point in series, it's going to take a higher pressure to push that blood through that narrow opening, and you're going to lose pressure as the blood goes from the left atrium to the left ventricle. So during filling of the left ventricle, there will be a pressure gradient between the left atrium and the left ventricle. So if we go down to the model here, then when you have mitral stenosis, you have a major resistance point in series that impairs the filling of the ventricle. So back upstream in the left atrium, you're going to get an increase in volume and an increase in pressure. In other words, it's associated with an enlarged left atrium. So in mitral stenosis, you'll have an enlarged left atrium, and the increase in pressure here can back up into the pulmonary circulation. Now, with time, you'll get a dilation of the atrium. So the atrium will enlarge with time. Now, in terms of that pressure gradient, they can test this showing the figure of the cardiac cycle. Now, they can show you this figure and simply ask you, what is the problem in the individual? Well, during filling, left ventricular diastolic pressure is usually the same as left atrial pressure. What we're showing here is the pressure gradient, the pressure loss going across the mitral valve. So in the filling phase, if the left atrial pressure is higher than left ventricular pressure, that is telling you it is mitral stenosis. Now, they're very big on murmurs. Now, you can just memorize the details, but again, if you work out the cardiac cycle, you can figure out exactly where the murmur should start. Now, the murmur is an opening problem of the mitral valve. So you say to yourself, where does the mitral valve open? It opens normally at this point here. This is S2. Therefore, it's easy to figure out that this murmur starts after S2, and it is a diastolic murmur. They may also test, because it's stenotic valve, you have an opening snap. So just to repeat that, you have to know it's a diastolic murmur that begins after S2. Now, in terms of the pressure volume loop, this state's pressure volume loop is not characteristic, doesn't identify the state, because basically you have an enlarged left atrium, and because you can't get the blood as easily into the left ventricle is usually smaller than normal. A very characteristic feature of this state is an enlarged left atrium, but a normal or smaller than normal left ventricle. Now, if you look at the pressure volume loop, the control loop right here, and compare it to mitral stenosis, what can you conclude about this loop? First of all, it is shifted to the left. Now, we mentioned if the loop is shifted to the right, the heart has enlarged. If it shifts to the left, it's a smaller heart. So with mitral stenosis, you expect a shift to the left. Now, because you have difficulty getting blood into the ventricle, preload goes down, and therefore stroke volume goes down, and peak pressure goes down. Just to repeat that, the pressure volume loop shifts to the left as a general change because the ventricle is smaller than normal in many cases. You have a problem getting the blood from the left atrium to the left ventricle. Preload goes down, stroke volume goes down, therefore systolic pressure goes down. But again, the loop does not help you identify the state, it's just a smaller ventricle. Now, the next state to take a look at is mitral insufficiency or mitral regurgitation. The generalization is the stenosis is fairly easy to deal with, but an incompetent valve is much more complicated. Now, with mitral regurgitation, you have a closing problem. Now, just follow me through on this. The mitral valve does not close properly. When does the mitral valve close? At the beginning of isovolumetric contraction. Since the valve does not close properly during isovolumetric contraction, blood is being pumped from the ventricle back into the atrium. You are losing blood from that ventricle during isovolumetric contraction. In other words, there is no isovolumetric contraction. During isovolumetric contraction, a volume of blood goes from the ventricle back into the atrium. Now, when the ventricle relaxes, the blood that was pumped into the atrium goes back into the ventricle. Now, the way I look at it is, with mitral insufficiency or regurgitation, a volume of blood goes from the atrium to the ventricle, back to the atrium. It cycles between the atrium and the ventricle. Because a volume cycles between the atrium and the ventricle, it should make sense. You expect an enlarged left atrium and an enlarged left ventricle. Now, going back to mitral stenosis, a characteristic feature of mitral stenosis was an enlarged left atrium, but a normal or smaller left ventricle. On the other hand, with mitral regurgitation, both the left atrium and the ventricle are enlarged. Now, there's a difference between the acute situation and the chronic situation. If we look at acute insufficiency, when you pump that blood back into the left atrium, the atrium has not had a chance to enlarge. Therefore, a given volume that enters the left atrium will cause a fairly large increase in pressure. So if we look at the cardiac cycle here, this would be acute mitral regurgitation. Because the atrium has not had a chance to enlarge, when you first pump some blood back in there and the atrium enlarges, it is very compliant. But very quickly, it becomes a stiff structure. And once it becomes a stiff structure, a further increase in volume further increases pressure. So you get a big increase in left atrial pressure, and that pressure can back up into the pulmonary circulation. In the chronic state, you have a chance for the atrium to enlarge. You get a dilated left atrium, and therefore that tends to reduce the pressure in the left atrium, but it increases the volume contained in the left atrium. Because the pressure doesn't go as high, chronically, peak left atrial pressure is reduced. Now, in terms of the pressure volume loop here, this is very characteristic. Now, this is very unique, and they can just throw this on the exam. Now, suppose this is your reference loop, and they show you this loop right here. Now, what is the one thing that strikes you when you look at this loop? It should be there is no isovolumetric contraction. You do not have isovolumetric contraction because when the ventricle contracts, it is pumping blood back into the atrium. Therefore, ventricular volume is decreasing. Now, it should be obvious there's an increase in preload because a volume is cycling between the atrium and ventricles. If you look at this loop, it appears you have a huge stroke volume. Now, you are pumping a large volume out of that ventricle, but a significant part of that volume goes into the atrium, not the aorta. Therefore, the stroke volume into the aorta can be reduced. That's why peak pressure may go down. A lot of people looking at this will see big stroke volume, but a decrease in ventricular systolic pressure. They don't correlate, but you know a lot of that volume is going back into the atrium. Now, if we consider the murmur, now again, you can figure out where the murmur should start. With mitral regurgitation, then, the mitral valve does not close properly. Therefore, the murmur should start where the mitral valve closes. Where does the mitral valve close? Approximately right here. That is S1. Therefore, this murmur should start at S1 and it can be a pan-systolic murmur. Now, the next problem is mitral valve prolapse. Now, we have very little information here because they're not going to test many details. In mitral valve prolapse, then, you have a valve that basically pushes back into the atrium during ventricular contraction more than usual, and it's usually identified as a mid-systolic click. There may be some incompetency in the valve. It's usually a benign problem, and I'm pretty sure they would not test any details on step 1. Now on this page, we are considering aortic stenosis. Now, aortic stenosis is an opening problem. The valve does not open properly, and because of that, it acts as a major resistance point in series. Because it acts as a major resistance point, you lose lots of pressure going across that valve. Really big point. Because it acts as a major resistance point in series, as you pump that blood through that narrow opening, you lose lots of pressure. Now, if we go to the cardiac cycle here and the major characteristics, the first major characteristic is left ventricular systolic pressure will be significantly elevated. Why do you need, or why do you have, an elevated left ventricular systolic pressure? That is because you need to develop more pressure to pump the blood through that narrow opening. So left ventricular systolic pressure is elevated. Now, with aortic pressure in the early stages of the disorder, aortic pressure is fairly normal. It can decrease in the later stages of the disorder, but initially it is normal. Therefore, systolic pressure is 120, diastolic pressure is 80. Now, the big point on this figure is you have a pressure gradient across that narrow opening when you're injecting blood. That pressure gradient is a pressure you're losing overcoming resistance. Now, this is the biggest point to remember. In aortic stenosis, you will always have left ventricular systolic pressure higher than aortic systolic pressure. Very characteristic of the disorder. Just to repeat that. If they tell you left ventricular systolic pressure is higher than aortic systolic pressure, that's all you have to know to conclude. It is aortic stenosis. Now, in terms of the pressure volume loop, if we go to the pressure volume loop here, this is our control loop. Now, it's not totally characteristic of the disorder here, but a major characteristic was you have an increase in systolic pressure. Now, you can't conclude too much because you don't have aortic pressure. If they gave you the information that left ventricular systolic pressure is greater than aortic pressure, then you conclude it is aortic stenosis. Now, this is an example of a pressure overload on the ventricle. And don't forget, in essential hypertension and now aortic stenosis, in the early stages of the disorder, there is no increase in preload. You got an increased performance. At a normal preload, you have an increase in contractility. You don't see the increased ejection fraction. Ejection fraction and stroke volume can be normal. Now, just to add a detail here, notice that this appears to be an elevated diastolic pressure. Well, this may appear on the loop because don't forget, stenotic valves open more slowly. Now, this loop would also represent essential hypertension. Because systolic pressure is up, it appears that diastolic pressure is up. So they cannot ask you to differentiate between aortic stenosis and essential hypertension unless they gave you some additional information. Now, in terms of the murmur here, now again, you can figure out exactly where the murmur should start. Now, this is your reference of S1 here. Closure of the mitral valve creates S1. Now, where would the murmur begin with the aortic stenosis? It's an opening problem. Therefore, it should occur right about here, because we got the abnormal cycle here. My point is, it starts after S1. So this murmur starts after S1. It's a very characteristic murmur, but I want to emphasize it starts after S1. Now we have a generalization at the bottom of the page here, and this is important to remember. The generalization is, and this applies to aortic stenosis and hypertension, a pressure overload on the ventricle is generally well tolerated short term, but poorly tolerated long term. Remember I said earlier, a pressure overload on the ventricle is very threatening long term. Now initially, there's no increase in preload. You get an increased performance as a result of increased contractility. Now the ventricle tries to compensate. It compensates by developing a concentric hypertrophy. Just to repeat a point here, a pressure overload is poorly tolerated long term. A pressure overload on the ventricle is very threatening long term, and the ventricle responds by developing a concentric hypertrophy. Now, as a consequence, you get a greatly thickened ventricular wall, and as a result, a reduced chamber size. And as you develop that concentric hypertrophy, initially it is compensatory, but later it is not a compensatory change. It is becoming a stiffer ventricle and a smaller chamber, and you will develop a diastolic dysfunction. A concentric hypertrophy is associated with a diastolic dysfunction. The ventricle becomes stiffer. Now, if we go back to the pressure volume loop, this is actually sort of indicated on the loop here. Notice this line is shifted upward. Okay, that's the beginning of a diastolic dysfunction, but it's not emphasized on the figure. Eventually, you will have a systolic dysfunction and the ventricle will fail. Now, the last valvular problem to consider is aortic insufficiency or regurgitation. Now, the insufficiency is more difficult to understand than the stenosis. Now, aortic insufficiency, regurgitation, is a closing problem. Now, just thinking this through carefully, the aortic valve does not close properly at the beginning of isovolumetric relaxation. During isovolumetric relaxation, a volume of blood is moving from the aorta into the ventricle. In other words, there is no isovolumetric relaxation. The ventricle is filling during that phase. This is a very characteristic feature of the disorder. Now, volume is flowing from the aorta back into the ventricle. Blood is also flowing from the atrium into the ventricle. Therefore, there should be a huge increase in end-diastolic volume. Aortic insufficiency is characterized by a big increase in preload. Now, if we go to the cardiac cycle figure, now in the insufficiency, you maintain compliance of the ventricle. Therefore, on this figure, you don't really see a big increase in end-diastolic pressure. What step one may say is you have a normal end-diastolic pressure less than 10 millimeters of mercury. In aortic insufficiency, they may give you an end-diastolic pressure of 11 or 12 millimeters of mercury. So end-diastolic pressure may be slightly above normal, but because you maintain compliance, there's a huge increase in end-diastolic volume. That means a big increase in preload. And a big increase in preload means an increased force of contraction. With an increased force of contraction, there's going to be a very large stroke volume going into the aorta. And we said that aortic systolic pressure is mainly determined by stroke volume. Therefore, because of the increased stroke volume, left ventricular systolic pressure is elevated, and it will be the same as left ventricular systolic pressure. Just to repeat that, you have a large stroke volume, which increases systolic pressure in the aorta, but you'll get an equal increase in left ventricular systolic pressure. Both are elevated, but they're the same number. That's a very big point to remember. Now, this is a more complicated aspect. Once you finish pumping that large volume into the aorta, blood is leaving the aorta and perfusing systemic tissues. but the aortic valve does not close properly. Therefore, blood is going back into the ventricle. In other words, you're very quickly emptying the aorta. Because of that, during aortic diastole, the pressure drops very quickly, and you end up with a low diastolic pressure. Very, very big point. Diastolic pressure is dramatically reduced because you're rapidly emptying the aorta. Now, systolic pressure is elevated, diastolic pressure is depressed, therefore you have a very large pulse pressure. Now, most clinical books will state that aortic insufficiency, and you got to remember this, is characterized by a very low diastolic blood pressure, but a very large pulse pressure. Just to repeat that, should be obvious. Aortic insufficiency regurgitation is characterized by a very low diastolic blood pressure, but a very large pulse pressure. Now, in terms of the murmur, you can figure out exactly where it starts. This is a closing problem. The closure of the aortic valve creates S2. Therefore, the murmur should start at S2, and it is a diastolic murmur. Now, at the bottom of the page, now if we take a look at the pressure volume loop. Now, because the ventricle is filling from the atrium and the aorta, there's a huge increase in preload. You have a volume overload on the ventricle, and the ventricle enlarges, the loop shifts to the right. Very big point. In severe aortic insufficiency, you can see some of the largest hearts you'll ever observe clinically. The loop is shifted away to the right. This is a chronic problem. So you have a huge increase in preload. Now don't forget, you've got a very low diastolic blood pressure, so you start ejecting blood into the aorta then at a lower pressure. You have a huge stroke volume that raises ventricular systolic pressure and aortic systolic pressure, but the most characteristic feature, the most unique aspect is you don't have isovolumetric relaxation. You are filling the ventricle during this phase. Now, step one likes to ask you about a major characteristic feature. So they could give you this control loop, and then they put a dashed line in, or I'm putting a solid line in, like this. They can ask you, what clinical situation would create this situation? Now, we just went through this, but if you think it through, you say to yourself, this is isovolumetric relaxation. This line is telling me I am filling the ventricle during isovolumetric relaxation, and that point immediately tells you it has to be aortic regurgitation. Now, we also have a generalization at the bottom of the page here. Now, the generalization is a large volume overload on the ventricle, as occurs in aortic regurgitation and a few other states, is often poorly tolerated acutely. A large volume overload can cause acute failure, but if it develops gradually over a period of time, it is generally well tolerated chronically. It is not that threatening if it develops gradually. Because it is not that threatening, the ventricle develops an eccentric hypertrophy. In an eccentric hypertrophy, you only have a modest increase in wall thickness. Compliance is maintained. There is no diastolic dysfunction. Failure usually is associated with a systolic dysfunction. Now, the right ventricle is somewhat different. The right ventricle acutely better tolerates a volume overload than it tolerates a pressure overload. So the right ventricle is basically opposite to the left ventricle. And that generalization is fairly important to remember. Now, there's one additional aspect I want to mention here. It's not in the handout. On step one, they can give you a case study and expect you to figure out the valvular problem. Now, there's some general rules here. The first rule is, and we're looking at left-sided problems specifically, do not start by looking at the size of the atrium. A lot of students start, because they give you that information early, they look at the size of the atrium, and they try and draw a conclusion. That's a mistake, because if you go through all 4 of these disorders, every one of them eventually can cause an enlarged left atrium. So telling you there's an enlarged left atrium means it could be any of the 4 disorders. Now, most clinicians recommend, if you're given the murmur, you start with the murmur. Now, suppose they only give you systolic versus diastolic murmurs. If they give you the fact that it's a systolic murmur, and you have these 4 possibilities, then you can eliminate 2 of them. Because if it's a systolic murmur, it could be either mitral regurgitation, or it could be aortic stenosis. Okay, so basically you've eliminated 2 of the 4. Now then, it depends upon the additional information, but suppose it's a physiology question and they give you pressures. Then you say to yourself, then what is the most characteristic feature of one of these disorders that sets it apart? And you should say, in aortic stenosis, left ventricular systolic pressure is higher than aortic pressure. So if they tell you left ventricular systolic pressure is higher than aortic pressure, the answer has to be aortic stenosis. Now there's different ways of approaching this. Mitral regurgitation is a volume overload. Aortic stenosis is a pressure overload. In both cases, you'll have a ventricular hypertrophy. However, in mitral regurgitation, it's a eccentric type of hypertrophy, modest increase in wall thickness, and an enlarged chamber. In aortic stenosis, because it's a pressure overload, you'd have a concentric hypertrophy. Now, there's other parameters to look at. I'm trying to give you a general way of narrowing down the best answer. Now, suppose instead they said diastolic murmur. Now, if you're dealing with these 4 disorders, again, there's just 2 possibilities. Number 1, it is aortic regurg. That's a possibility. Number 2, it could be mitral stenosis then. Now, again, what you may say to yourself is there something really, really characteristic of these 2 disorders? Hopefully you'd say to yourself, if it's aortic regurg, it is characterized by a very low diastolic pressure, but a very big pulse pressure. If they give you that information, it has to be mitral regurgitation, not mitral stenosis. Now, they could say an enlarged left ventricle. If they say an enlarged left ventricle, just looking at this, it has to be aortic regurgitation. There's a volume overload there. Okay, it is not mitral stenosis, because in mitral stenosis we have a normal or smaller than normal left ventricle. Now, what I'm trying to do is to get you thinking about major characteristics here that separate the possibilities. Don't forget in step 1, they give you 5 choices. Sometimes in these disorders, they just give you 4 choices. And you can start by eliminating a couple of possibilities if you don't see the correct answer immediately. And again, you need to go to your computer bank questions and practice answering some of these type questions. What I want to consider now is shunting of blood in the heart. Now, there is an assumption when we take a look at these atrial and ventricular septal defects. The assumption is, unless you're given information to the contrary, then you assume that pressures are higher on the left side of the heart than they are on the right side of the heart. That means left atrial pressure is higher than right atrial pressure under normal conditions. Therefore, if you have an atrial septal defect or a ventricular septal defect, you assume the flow is from the left atrium to the right atrium. And remember, the PO2s on the left side of the heart are 100. The PO2s on the right side of the heart are 40. Therefore, if you shunt blood from the left atrium or the left ventricle to the right side of the heart, high PO2 blood is moving from the left heart to the right heart. And it should make sense. If you have this left to right shunt, there is no hypoxemia. So a left to right shunt never causes hypoxemia. Now, if we start by considering an atrial septal defect, if you have a hole in the atrial septum because pressure is higher in the left atrium than the right atrium, high PO2 blood goes from the left atrium to the right atrium. So you have high PO2 blood flowing from the left atrium to the right atrium. Now, because high PO2 blood is entering the right atrium, its PO2 increases then. Now, that higher PO2 blood is carried into the right ventricle and pumped into the pulmonary arterial system. So this left to right shunt raises right atrial PO2, right ventricular PO2, and pulmonary arterial PO2. And because blood is flowing from the left atrium to the right atrium, you overall have a volume overload on the right heart. Therefore, the output of the right heart is now greater than the output of the left heart. And we mentioned earlier, if you have a selective increase in the output of the right heart, it delays the closing of the pulmonic valve, and that can cause you to hear a splitting of the second heart sound. So with atrial septal defect, you can have a splitting of the second heart sound for the reasons we just went through. If we go to the bottom of the page, instead of an atrial septal defect, we can consider a ventricular septal defect. Now, in a ventricular septal defect, you will have blood flowing from the left ventricle to the right ventricle. But again, it's high PO2 blood going from the left heart to the right heart. Now, the difference in this case is there is no increase in right atrial PO2, but there is an increase in right ventricular PO2. And because you have a left to right shunt, the output of the right ventricle is now going to be selectively increased. It is again greater than the output of the left ventricle. And because you have that selective increase in the output of the right ventricle, you can hear splitting of the second heart sound during the respiratory cycle. Now, the way they usually test this in step one is using a Swan-Ganz catheter. You introduce that into a systemic vein, and we talked about the details of that earlier. And when you insert that Swan-Ganz catheter, it goes through the systemic vein, it goes through the right atrium, the right ventricle, into the pulmonary arterial system. And you take blood samples, usually when you withdraw that catheter, and in this case, to identify a septal defect, you measure the PO2s in the various compartments that that Swan-Ganz catheter is passing. Now, this is the bottom line. You take the systemic venous PO2 as a reference. Now, they may not give you 40 as a reference. They'll give you maybe 35. If there's no left to right shunt in the heart, that PO2 of 35 is carried through the right atrium, the right ventricle, and into the pulmonary arterial system. If they tell you systemic venous PO2 is 35 and the right atrial PO2 is significantly higher than 35, you stop. You know the answer is atrial septal defect. On the other hand, if systemic venous PO2 is 35, right atrial PO2 is 35, but right ventricular PO2 is significantly higher than 35, then again you stop. You know the answer is ventricular septal defect. Very easy to identify. And finally, don't forget in these figures, the thicker lines indicate a volume overload in that particular compartment. Now, that's probably all they're going to test in step one, but there's one additional aspect that's worth mentioning here. They may talk about a young woman in which right atrial pressure goes higher than left atrial pressure for some reason. If right atrial pressure goes above left atrial pressure, you may reopen the foramen ovale. If you reopen the foramen ovale, and because right atrial pressure is elevated, you now have low PO2 blood going from the right atrium to the left atrium. Now, this is a right to left shunt. So low PO2 blood is going from the right atrium into the left atrium. That would decrease the PO2 of the blood pumped by the left heart. That is a right to left shunt, and that would cause hypoxemia. And that is part of Eisenmenger syndrome. That's a possibility for step one, but that's probably the only additional aspect I think they would test related to this page. Now, there's a possibility they can test the consequences of a patent ductus. A ductus is not closed after delivery. Now, this is one where people make a common mistake. But again, we can go to this model here then. Now, in a patent ductus, then you maintain flow from the aorta into the pulmonary artery. And it should be obvious, the blood flowing from the aorta to the pulmonary artery has a PO2 of 100. Again, this is a left to right shunt, and arterial PO2 is normal. There's no hypoxemia. The difference here is that this blood that is shunted into the pulmonary artery returns to the left heart. So unlike the previous two, a patent ductus is a volume overload on the left heart, not the right heart. Just to repeat that volume that goes through that patent ductus into the pulmonary artery goes through the pulmonary circulation and returns to the left heart. So a patent ductus causes a chronic volume overload on the left heart, not an enlargement of the right heart. Again, they can test sampling from a Swan-Ganz catheter. It's not very likely with this disorder, but you can figure out exactly what you would find. You would start with systemic venous PO2 and a patent ductus. The same number should be in the right atrium. The same number should be in the right ventricle. But once you get into the pulmonary arterial system, the PO2 increases. Now, in addition here, and again, this is probably a step 2 question, if you maintain a patent ductus and you have an increased volume going through the pulmonary circulation, in some cases, you can get pulmonary hypertension. If you have pulmonary hypertension, then this shunt can reverse. So when it reverses, low PO2 blood from the pulmonary artery enters the descending aorta, not the ascending aorta. Because it enters the descending aorta, the lower body will turn blue, but the upper body remains pink. Now you can think that through, and that is probably a little bit beyond step 1. Now, in terms of murmurs, you should be aware of the 4 situations at the top of the page that will create a murmur. But our focus here are the systolic and diastolic murmurs created by heart valve problems. Now, the first determination to make is whether the murmur is a systolic murmur or a diastolic murmur. Now, if you determine it is a systolic murmur, there's 2 main murmurs you'll have to deal with. The first one we'll say is an ejection murmur created by either aortic stenosis or pulmonic stenosis. This murmur begins after S1, but it is a crescendo, decrescendo murmur. The big point to remember is the ejection murmur will be a crescendo, decrescendo murmur starting after S1. It is not a pan-systolic murmur. Note the location where you would best hear aortic stenosis and the location for pulmonic stenosis. Now, the second systolic murmur is a pan-systolic murmur. It begins at S1 and goes to S2. It has a fairly constant intensity. This will be either mitral insufficiency or pulmonary insufficiency. Again, on the chest diagram, note the location. You hear tricuspid insufficiency versus mitral insufficiency. So the 2 main murmurs here will be an ejection murmur. You have a crescendo, decrescendo murmur beginning after S1, and a pan-systolic murmur, holosystolic murmur that goes from S1 to S2, a fairly constant intensity. And that will be tricuspid insufficiency or mitral insufficiency. There is a third possibility for a systolic murmur. It can be a late systolic murmur, but the most characteristic feature is a mid-systolic click. This would represent either mitral or tricuspid valve prolapse. Now, this is a fairly common disorder, usually benign. The late systolic murmur is due to a mild insufficiency created by the condition. Now, in terms of diastolic murmurs, there's only 2 that we have to deal with here. The first one is aortic or pulmonic insufficiency. Now, aortic insufficiency, pulmonic insufficiency, and they'll test aortic insufficiency in most cases. It's an early diastolic decrescendo murmur. So with aortic insufficiency, it will be an early diastolic murmur that is, it's an early diastolic decrescendo murmur. It begins at S2. Now, in terms of hearing the murmur, it tends to radiate down the left side of the sternum. So it's not the aortic area, it is the left side of the sternum is when you tend to hear this murmur. Now, if you have aortic insufficiency, don't forget you can confirm this by measuring the patient's blood pressure. We made a big point of saying earlier, with aortic insufficiency, systolic pressure goes up, diastolic pressure goes down, and you have a large pulse pressure. The basic characteristic is you have a very low diastolic pressure with a large pulse pressure. That is going to be consistent with aortic insufficiency. Now, the other diastolic murmur will be a mid to late diastolic murmur. It's described as a rumbling mid to late diastolic murmur with an opening snap. This will be either mitral stenosis or tricuspid stenosis. So in summary here, if it's a diastolic murmur and it's an early diastolic decrescendo murmur, then beginning at S1, it's aortic insufficiency in most cases, and that can be confirmed by measuring the patient's blood pressure. The other is a mid to late diastolic murmur with an opening snap. That will be either mitral stenosis or tricuspid stenosis. Now, what we've been going through is the most fundamental information concerning murmurs. Pathology may add some additional murmur details as well as some other murmurs. Now, in Chapter 14, you went through in detail the cardiac cycle. You can now draw and sketch your own basic cardiac cycle and interpret that figure. You can correlate the pressure changes in the cardiac cycle with the EKG. You can also correlate the pressure curves in the EKG with the ventricular action potential and the atrial action potential. You can define specific points in the cardiac cycle where channels are opening or closing in both the atrium and the ventricle.